Hello again. We are now going to see the second part of this lecture on the Sylvian arachnoid cysts in children, and this is about the management and results. And this is illustrated by a French saying that if there is no solution, there is no problem, which is often the case, but also if there is no problem, there is no solution, we should add. So, as you know, as said before, the Sylvian arachnoid cysts are the epitome of incidentaloma. We can call them vomits, that is, the victims of modern imaging technology. But they have sometimes an unexpected behavior, which can go badly with progression or bleeding, or in the right direction with spontaneous cure. So it's very difficult to make a decision and to decide for surgical indications and which surgery. So we have like the justice, we shall have to withhold our sword and ponder the indications. So when do we have to operate? When there is raised ICP, because we can see massive fake on the imaging, there is papilledema, there are clinical symptoms which are often difficult to ascertain in small children. Epilepsy is a question because normally the cyst is not causing epilepsy, but it is the reason for doing the imaging. So it is often an incidentaloma. Deficits are rare in arachnoid cysts, and imaging can be difficult to interpret as we have seen. And on the other side, we can have a risk of complications like subdural collection, but the subdural collection can be the cause of the diagnosis. We can also have progressive skull deformation and sometimes vasospasm caused by the compression of the arteries by the cyst. So how do we operate? We can just wait and see, which is the most pleasant way of managing these patients, or we may have to put a shunt, or we can have to do a craniotomy, and finally the endoscopy, which is, I shall say, my favorite technique for these cysts. So we have seen already these statistics. We know that asymptomatic patients in almost all cases stay asymptomatic. They do not complicate with subdural hematoma. So this requires just follow-up or maybe just even leaving them alone. And how long should we follow them? Certainly for a few years when they are young, but in most cases there is nothing to do. And certainly we should not create artificial problems by following them closely because these patients are not sick. First, the endoscopy. It is a very attractive technique for this cyst because we can fenestrate the cavity into the basal system. We have a wide access to the system, and we have just to push our endoscope through the membranes to fenestrate the cyst into the basal systems, but they have to be as accessible. So this is the kind of landscapes that we have. We shall detail that very soon. And it is minimally invasive, it is fast, it is easy, but maybe we can consider it risky because, as you can see, there are many things which have to be respected, like the vessels, the optic nerve. So the indication should not be taken lightly. And it has been considered that it avoids subdural collections because it maintains the intracranial pressure, but also we can see a few cases, and we have some illustration of that, where it provokes the subdural, and the risk of subdural collection is maximal in infants, for which the risk of subdural collection is important after any trauma, including surgery. So this is a small video about the endoscopic fenestration of the Sylvian arachnoid cyst. So we are going to see first this large cyst with a mass effect, and this is where we want to go. And here is the landscape that we have. We can see the pulsation of the CSF in the cyst. We can see the branches of the middle cerebral arteries. So we have the temporal lobe, the temporal edge, and the middle cerebral artery. And we are going to perforate the membrane of the cyst behind the carotido-sylvian axis. So we do perforation with a scissor. We can cut the membranes until we can introduce the neuroballoon between into the prepontine system. And here we explore the perforation we've made, and we see there are many vessels which have to be respected. We can do further dissection of the cyst, and in the end we have the choroidal artery and the posterior cerebral arteries which can be seen. And this is another hole we do in front of the carotid artery between the carotid and the optic nerve. And this is a result of the surgery. We can be very happy with the imaging, but we also have to follow this patient because of the risk of secondary complications. So the outcome can be satisfying. In this case, the patient was very much improved, the papilloma subsided, but as you can see, the imaging shows little diminution of the volume of this cyst, but it is as good as we can get. On the other so the results are often partial, and on the other hand, we can have poor results in this baby, 13 months old, who had microcrania. We did some surgery by endoscopy, but on the second operative day, he had CSF leakage, and there was some subdural collection on both sides. So we did an external drainage because there was some a doubt about infection, and then internal drainage, which was removed after a few months, and the result is not so bad. So, as you can see, the criteria for success are often dubious, while the criteria for failure are more than obvious. Then shunting, it is the by default solution. It has a dramatic effect on imaging, but it creates shunt dependency, and this shunt dependency can be problematic when the cyst is very small and the shunt has to be revised. So this is an example when there is a small cyst, although it is under high pressure. It can also be the only solution in very small babies, like this one, who had a shunt which was a bit oversized, but it was anticipating the growth of the child, should we say. And also, sometimes there is a CSF absorption problem which appears after another technique. This is a baby who had a subdural collection, which was shunted. After shunt removal, he developed severe symptoms of a raised ICP, although the cyst was very small, and he needed a cystoperitoneal valve. So this is, as you see, the by default solution, and this is not, of course, very satisfactory to create shunt dependency. So we can sometimes do a membranectomy. This is a child where we have a cyst which would have been eligible for endoscopy surgery, except that there was a mantle of cortex, and we don't like going through the temporal pole with the endoscope because of the risk of vascular lesions on the outer or inner aspect of the temporal pole, and so we decided to do a small craniotomy with opening of the cyst, and inside the cyst we could do a resection of the membranes and have this kind of beautiful landmark. But it's a large surgery with a risk of vascular lesions, of course. Sometimes the cyst can be very atypical. This is a very small baby who where diagnosis of a mixed Sylvian and supracellular cyst was made before surgery, and at birth he was very sick, very hypotonic. The motor reflex was absent. He was bradycardic. The Bernstein potential were very poor, and we decided to do an open surgery. And you see after birth, the cysts were extended also in the posterior fossa. And we did a craniotomy and a resection of the membrane, and in the end, there was a very questionable tissue here, which was not expected. It was in front of the brainstem. And in fact, on the posterior operative MRI, we found that it was a hypothalamic hamartoma, so which was not disclosed before surgery. And this is a rare association between hypothalamic hamartoma and middle cerebral artery cyst. Sometimes we have a bump which has to be corrected, like in this child. We did a reshaping of the temporal squama doing a daisy flower cranioplasty, which was successful, although the child was not very happy when she saw me again. So it can be very easily done. And sometimes it can require a major surgery, like in this teenager who had a huge middle temporal cyst, with huge bulging and also deformation of the orbit. So it was a craniofacial surgery associated with a membranectomy, with a good result. So this is the series in my experience in Lille. When there is a subdural collection, there is no question of approaching the cyst. The problem is the subdural, and in the few cases which were treated with approach to the cyst, 9 of the 11 cases failed. Then we did, in most cases, we did a subdural drainage, which has also a significant rate of failure, but less than approach to the cyst, of course. And when we treat subdural collection associated with a cyst, we have to wonder whether we put a valve or not. Sometimes the CSF can be bloody. So we have to check on the MRI what the signal of the collection is. And during surgery, if it is clear as water, obviously we have to put a shunt with a valve. There are many complications with hypodrainage or overdrainage, and it is very difficult to predict. So we have to warn the patient and his parents that this operation may not be the only one, and also absolutely avoid pressure-related valves. So to summarize, membranectomy is a major surgery, endoscopy is minimal, and cyst drainage is the by default technique. So subdural drainage is a temporary method in most cases, but not always. The drawback of membranectomy is that it is invasive. The endoscopy is has better results, but also has a complication rate of 20% of subdural. Cyst drainage, of course, it creates shunt dependence, and subdural drainage often does as well. So the cyst reduction is maximal with the drainage of the cyst, but it can also be good in membranectomy and endoscopy. The clinical efficacy is very good in all of this surgery, especially subdural drainage, because these patients arrive with severe intracranial hypertension. We can have some over drainage when we put a valve inside the cyst, but as I said, it has to be anticipated. The reoperation rate is high in membranectomy, but it depends much on the different series published. In endoscopy, it's about 47% at 5 years, so it is far from negligible. And we have also a number of reoperation in a cyst drainage. In a subdural drainage, it can happen also. So the age to which these operations address is mostly in older children for membranectomy. The median age for endoscopy was 3.6 months in my experience. No, years, excuse me. While it was 12.2 years in cyst drainage, so mostly older children, and also subdural drainage in older children. So the long-term results were good, I think, in membranectomy. They were stable in endoscopy, who were not reoperated. The problem, as I said, of shunt drainage is that these patients were shunt dependent, and subdural drainage, in most cases, could be removed. So the main indications for membranectomy is when you need to do a cranioplasty. For the endoscopy, when there is a compressive cyst which is accessible from the dural aspect. Cyst drainage, I think the best indication is in newborns and very small infants, and subdural drainage, of course, in subdural hematoma. So my preferred technique, as you understand, is endoscopy. It has been these different techniques have been compared in this review, which considers that all methods are effective, but endoscopic fenestration is the best initial procedure, which understates that there may be more. So in conclusion, we have first to ask whether our patient is symptomatic, and if we think not, we have to be sure that he is not. We have to ask whether the risk-benefit balance of the surgery is favorable, which is, as I said earlier, different according to the technique, and more in favor of endoscopic treatment. And if the patient is asymptomatic, he should live a normal life, as I said previously. I thank you for your attention.